how early or how old would someone have to be to start a medical treatment like finasteride or
Yeah.
minoxidil?
We'll see many young men, particularly, and I'll come to women in a moment because we think about men and women in hair loss treatment a bit differently. There are some overlaps and similarities, but I think women's hair loss on the whole is actually more complex and needs a bit of a different approach. But on the male hair loss side, particularly for pattern hair loss, for some reason we seem to be seeing it earlier and earlier. It's not uncommon for men to come to us in their 20s with hair loss. That's young. That's fine to start treatment at that age. People need to recognize if they are at risk for hair loss and they're starting to thin. In general, if it's pattern hair loss or androgenetic alopecia or androgenic alopecia, as some call it, you are going to be on your treatment. If you want to maintain your hair growth, you are going to be on it long term. And I say to people, just understand that. It's like I take a pill for cholesterol. If I stop taking that pill, my cholesterol will go up. So it's my choice. If you stop taking your hair loss medications, your hair will revert to what it's genetically intended to be at that stage in your life. So you need to be on treatment long term. Men in their 20s, 30s, 40s, 50s, treatments will work. We've got patients, and I've got friends of mine who started treatments in their late 50s at 60 with excellent effect in terms of hair growth. So there isn't really an absolute cutoff one way or the other. We don't like to treat kids because altering testosterone, we want to make sure you've gone through puberty, you've had your sexual maturation. But usually men in their 20s should be absolutely fine for treating. Now, women, it's different because we have to be very, very thoughtful about what medications we use in women for their hair loss. And of course, drugs like 5-alpha-reductase inhibitors, like finasteride or dutasteride, are generally preferred not to be used in women of childbearing potential because they can have an effect on the sexual maturation of a fetus. And so these types of medications you would typically avoid, and that's a discussion a woman will have to have with their doctor if they happen to be pregnant with a lot of hair loss. Of course, there are other possibilities for women, and depending on what the cause of their hair loss is. Spironolactone is a very commonly used agent, as is minoxidil for female hair loss, and more minoxidil is being used in its oral form. Lower doses of oral minoxidil can be quite beneficial. For women, we tend to really think about pregnancy and potential as a key factor in our decision of what to use and when. But depending on the extent of hair loss, even a younger woman may warrant treatment. Low-level light laser therapy for certain types of hair loss may be helpful as well. Some will use it for telogen effluvium, which is a stress-induced loss of hair. But some would also advocate for low-level light in androgenic pattern hair loss too. But age is important, more so I'd say in women than in men.
What's the youngest you can prescribe someone finasteride? Is it 18 or is it?
I would say 19 and older. I'm not sure I've ever prescribed someone as young as that, but certainly early to mid-20s. And these are typically cases where young men have got a very profound family history and they've really got accelerated hair loss at a young age, where you know it's androgenic and you know it's going to be severe. And that individual really wants to do everything they can to stop it.
Mm-hmm.
I would not, in an individual, even if they're young, I would not spend 6 to 12 months on vitamins or shampoos alone if they have accelerated hair loss and they want to keep their hair. I would get in and treat soon. And generally, one can do that very safely today, Zeph, as you know. I mean, there are obviously FDA-approved options of oral finasteride and topical minoxidil. There's a number of compounding options that are available depending on the preference of the doctor and the patient, certain compounding topical agents that limit absorption. So there's a variety of options, fortunately, for patients available today that can be decided upon based on their stage of life, their preferences, et cetera, et cetera. For some, oral agents may be just fine. They're not going to have sexual dysfunction, they tolerate it fine. And for others who are really concerned about sexual function or who experience it, for them, maybe a topical application that reduces absorption is better. It's a personal preference with the doctor and the patient.
With oral medication and taking it long term, if you have to start it young, you're going to want to be on it long term. What's the long term health risk of taking finasteride orally or minoxidil long term orally? That could be
Yeah,
an option actually, but
yeah,
let's start with finasteride itself for long term medication orally.
yeah. Zeph, remember, finasteride was approved for two indications at the higher dose for benign prostatic hyperplasia, or BPH. It's an increase in the size of the prostate gland, and then at the low 1 milligram dose for pattern hair loss. Those studies would have included many, many hundreds, and in some cases, thousands of patients. And in many of them, based on the FDA requirement, they actually require long-term studies. Typically, the FDA, to approve a drug, requires a minimum of 1 year safety in at least 100 patients and a minimum of 6 months safety in 300 patients. That's the minimum sort of regulatory requirement today. But we know from finasteride, which has now been available for decades, I think, let me just do, there we go.
All right, you're all set?
All set.
Cool, I'm recording. We're on the subject of oral finasteride and taking it for a long term if someone needs to be on it for a long time, and the potential health risks of being on oral medication like finasteride for a long period of time and what those health risks might be.
Right. Zeph, yeah, it's important to consider when you start a medicine like finasteride, not just what the side effects may be early, but, you know, obviously safety, tolerability, and long-term as well. I think it is important to know that when the FDA approves a medicine like finasteride for androgenetic alopecia, it's gone through extensive testing, and part of that testing is safety, and part of that safety is long-term. With all medicines, they have to go through long-term safety testing in what's called non-clinical models. These are generally animal models, and, you know, a lot of people hate animal testing, as I do, but it is a necessary evil in approval of drugs. Hopefully one day we can develop systems that allow us to develop medicines without that. But also long-term testing in humans. And I would say on top of that long-term testing, which of course was done on finasteride, we now have studies of finasteride for many, many, many years, and then clinical experience for even longer, talking decades. The drug has been around and used for decades for both benign prostatic hyperplasia and for androgenic alopecia. And so we really do have long-term use knowledge of medicines like finasteride. And on the whole, the reason the drug is approved and available and is widely used is because of general long-term safety. With any medicine, Zeph, there's always a potential for adverse effects, some acute and some delayed and some chronic. You know, a lot's been said about the seemingly innocuous medicine called aspirin, which people take all the time. There's a reasonable chance aspirin wouldn't be approved by the FDA today because of its risk of stomach ulcers and bleeds, gastric bleeds. You know, yet people use it a dime a dozen. And I'm not supporting that, but it happens. So with any drug like finasteride, there is a potential for adverse effects, although the risk of those long-term with finasteride, based on extensive studies, decades of clinical experience, seems to be very low. And the major potential liability of drugs in that class would be based on the effect of the impact on the testosterone to DHT production. And if you're blocking that, the impact of that on sexual function, libido, erectile function, testicular function, potential for infertility, gynecomastia, which is tenderness and swelling of the breast tissue, including in males, we have breast tissue. And so these would probably be the more relevant adverse effects to consider over time. But in general, for the majority of people, whether it's taken orally or whether it's done in a compounded form, finasteride long-term appears to have a good safety record.
And would you say that finasteride is something that suppresses testosterone, or obviously it depresses dihydrotestosterone, but people that take it are afraid of obviously the short-term sexual side effects. Um, what do you think about the long-term sexual side effects if you decided to get off the medication? People are very scared of the post-finasteride syndrome. I have my opinion about it, but I would love to hear what you think about it.
Yeah, look, it's a very commonly asked question, and it's a common concern in people. Obviously, having a risk of sexual dysfunction acutely is one thing. Having it as a potential permanent risk long term is very significant for most people. I think based on how we know finasteride works, it's relatively short acting. Its half-life is about 5 or 6 hours. It gets out the system pretty quickly. It doesn't competitively block DHT production. It doesn't bind to that 5-alpha reductase permanently. It's very unlikely from a physiological perspective that the use of finasteride will result in long-term sexual dysfunction once the drug is stopped or removed. Finasteride gets removed from your system, and it doesn't sort of reset your hypothalamic pituitary testicular axis, which is the hormonal axis that generates testosterone, generates desire, helps with erectile function, fertility, these types of things. There isn't evidence that once you remove finasteride, you have an impact on your key, what's known as the Leydig cells in the testes, which produce testosterone. There really isn't evidence that after removal of finasteride, you have depression of that production long term. And so, as I say to people, when we think about sexual dysfunction with finasteride and dutasteride, we've also got to recognize there's a very, very strong influence of a natural physiologic phenomenon in sexual function that men have. We know if you gave 100 men placebo for a year, they just take a totally inert, an M&M, a good proportion of them will have complained of sexual dysfunction on that placebo or that M&M at some point during the year. It's part of normal physiologic ups and downs when we're fatigued, when we're stressed, when we gain weight, when we're not feeling well. All of these are factors that can impact sexual function. It's very, very easy to always pinpoint a medicine.
I think I think that's the most common thing is people are they're already having these issues, and because they're on that medication, they like to pinpoint and blame it when it could be lack of sleep, it could be they haven't eaten in the last, 12 hours or whatever the
Chronic
case.
stress,
I think a lot of
depression.
people do.
Yeah, we see it with anxiety, with depression. The other thing that we'll sometimes see is if people go on a 5-alpha reductase inhibitor, whether it's oral, whether it's topical, finasteride, or dutasteride, and within one day, they've got sexual dysfunction.
Yeah.
The amount of that DHT reduction in one day is relatively so small. Again, nothing, I like to say in medicine, nothing's impossible. But we've got to look at likelihoods based on physiology, based on how the drug works, how it impacts the body, how it reduces DHT, how long that takes, how sustained it is. And it's very, very unlikely that a day or two of finasteride or dutasteride use is going to be a culprit. It's much more likely that if that individual took nothing, they would have it. Remember, when you start taking a medicine like finasteride, there's an anxiety taking that medicine of what that risk might be.
The fear of it.
The fear of it. And so we see this in patients all the time in different types of treatments. I treat a lot of patients with heart disease, with cholesterol lowering. Those cholesterol lowering medicines are known to cause, in some people, muscle aches, muscle pains, muscle weakness, guys who are wanting to work out. Now, in some people, that's legitimate. In others, they go on the medicine, they know they're probably going to get muscle pains and muscle aches and muscle weakness. So it's more likely to happen. It's the same with sexual dysfunction. The more you think the drug may have an effect, the more likely it is. Remember, people have to remember when we do clinical trials of medicines, let's say it's a drug to treat pain. When you compare the active treatment arm, the medicine, to the placebo arm, your placebo is reducing pain by 30+%, whereas your active is maybe reducing it 40%. That's the reality. Placebo response to medicines is huge, particularly when you have a worry of what that medicine actually might do,
Yes.
like your sexual function. I'm going back to my earlier point, 100 men over a year, almost every one of them is going to at some point have some complaint of sexual dysfunction. Performance isn't as good, erections are not as good. And as we age, Zeph, that's way more common. Guys in their 40s and their 50s, way, way more common to get sexual dysfunction for totally other reasons, right? I'm not saying it can't be drug related, but I think it needs to be looked at in the context of normal and or other abnormal variability in sexual function from other causes. Of course, medicines are a potential risk for sure, but they're certainly not the only risk.
And finasteride, with finasteride suppressing DHT, how much does DHT play in a part of sexual function?
Yeah, I mean, it's a very good question. I mean, obviously testosterone is a key androgen for sexual function, and particularly your free form. Remember, testosterone is often bound to proteins. Sex hormone binding globulin is a very important protein testosterone binds to. Albumin is another protein testosterone binds to. Those are not your active forms. The active is the free form. That's why it's important when you get testosterone measured. You should have it measured in the morning. You shouldn't have engaged in sexual activity for 48 hours. And you should definitely measure your free testosterone, your bioavailable or bioactive form. And so that's the primary driver. Of course, DHT will have some contribution as well. And we know that also by the fact that in some people, really strong inhibition of DHT with 5-alpha lactase inhibitors can cause sexual dysfunction. So that is not because of its reduction on testosterone, it's because of its reduction on dihydrotestosterone. So I always think about testosterone as your main androgen driver, but DHT we know is playing a role. Maybe it's a bit of a smaller role than testosterone, but it's an important role. And of course, with women, it's also a very interesting phenomenon because with women, minor changes may really alter that estrogen testosterone balance, whereas men kind of have more reserve. So you can sort of push that system down a little bit more in men. But no, I would say testosterone is your main driver of sexual function, but DHT is playing a very important role as well.
Yeah, I always tell people if finasteride was suppressing your free testosterone, or if it was suppressing your dihydrotestosterone, why are there so many people that are able to function on the medication sexually if they're suppressing their DHT? If DHT is the most important thing to sexual function, you would think 100% of people would have sexual dysfunction on the medication versus, not. So I always tell people it's a small percentage, but it is.
I mean, look, what we do know is interesting. A lot of our learnings in medicine come from natural experiments, really. It's genetic disorders where mutations occur in genes naturally in people. And a lot of our learnings about 5-alpha reductase and DHT come from families, I believe they're from Puerto Rico originally, who had deficiency of 5-alpha reductase enzyme, genetic disorder. 5-alpha reductase is missing. They're not producing DHT. And these young men, as they went through puberty, didn't have development of the prostate, were infertile, and had hair growth abnormalities as well. And so we learned about the effect of DHT on the prostate, on the hair, on fertility, on sexual function. In addition, we learned so much from these biological variations where 5-alpha reductase is missing and DHT is not being produced. That does lead to infertility. That does lead to poor development or lack of development of the prostate and sexual organs. And so DHT clearly is playing a role. It's clearly playing a role, and we learned that from the 5-alpha reductase deficiency story.
Yeah, and what would you say about what's the benefits, pros and cons, or just the comparison? Why would I take a topical finasteride versus a oral finasteride?
Yeah. Well, let's remember the approved form for androgenic alopecia is oral finasteride at a 1 milligram dose. Um, the reason that some doctors will opt and some patients would prefer topical is in cases where they do have worries about sexual function, or they've experienced sexual function with the oral form and would like to try a formulation that can be compounded that will better distribute the medication in the scalp with less absorption systemically. So in other words, a form that's going to have less impact on DHT in the body. And some topical forms do that, not all. I mean, some topical solutions just allow the medicine to go through and it's systemic. But there are some forms that have been specifically formulated. Our pharmacists actually have that available in a form of a gel, which is specifically formulated where doctors can actually prescribe finasteride in this gel in a way that limits the absorption. And those studies have been done in human patients, showing more limited absorption and more limited effect on DHT. So probably for the majority of people where sexual function is not a problem, oral finasteride is just fine. It's been studied, it's approved. For those where sexual function is a problem or a concern, topical forms have been used very, very successfully. And there actually are a number of clinical trials now using topical forms of finasteride and or dutasteride with very good effect. And so we know that blocking DHT in the skin is probably sufficient. You don't need to block it systemically in the body to improve on hair growth or retention of the hair you have. Blocking it in the scalp is enough. And so for some men, they say, well, why would I want to inhibit DHT elsewhere if blocking it in the scalp is sufficient? And that we know. Blocking it in the scalp today, we know is sufficient. So it's really a conversation that as a patient one would have with your doctor as to which is best suited for you. We always advocate, at Zion, you go with the approved medicine if that's good for you and that's what you want. If you need something different, that's a discussion to have with the doctor, and there are compounded forms available if that makes sense.
Yeah, and me just being a testament to taking oral medication and the topical and trying both, that I've had a similar experience with the oral medication and having the unpleasant side effects, and taking the topical and not really experiencing something that I can pinpoint like, oh, this is definitely affecting me. So
yeah, well, we know, Zeph, from some of the studies we did in patients, when you take the oral form, we knock DHT down by probably around 80 plus or minus 80%, 70 to 80%. With dutasteride, it's about 90%. You have even greater suppression systemically. When you deliver those topically in a formulation that has been designed to limit the uptake of these medicines into the body, the effect on systemic DHT is much lower. In the case of topical dutasteride, it's about a 10% reduction versus 90%. I mean, that's night and day. With finasteride, it's about 10 to 20% versus 70 to 80%. So we know that you have very significant lowering of that systemic effect on DHT with certain topical forms. Not all topical forms. I have a saying I've used for years. Not all topicals are created equal. Just because something's topical doesn't mean it's not getting into the body. We know in medicine we use patch technology specifically to drive the uptake of medicines into the body. Topical medicines do the same. People who take Voltaren gel for aches and pains, for injuries, they can get stomach ulcers. It's the same as taking an oral anti-inflammatory, because that Voltaren as an anti-inflammatory gets taken up into the body. Now, fortunately, that's not that common, but that can happen. So these topicals don't suppress uptake to a large degree unless they're designed specifically to do that and cause this depot on the skin.
And
Somehow.
And what do you guys do for testing obviously you can test the systemic absorption of these medications and you talk about localizing the medication. What
Right.
do you guys do to test the localization of the medication for your topical gel?
Yeah, there are tests we use that have been used in the industry for decades called France cell experiments. And essentially with a France cell, you get, usually it's human cadaver skin. It's been excised or it's excised from surgery. Someone goes for a certain surgical procedure, they get some skin cut, and there are people that supply that skin
Mhm.
for research purposes. You can also use mini pig skin, similarly, that gets harvested for these purposes. And essentially what you can do is there, through a front cell experiment, you can run a medicine in a certain formulation into a chamber onto the skin layer, and you can measure the amount of that medicine underneath that layer in the receptor,
Mhm.
as well as the amount of medicine that stays resident in the skin. And those have been used for decades to study topical formulations to give us an ability to predict how much of the drug gets through and how much stays in the skin. Um, and they're reasonably accurate. I mean, you can never say it's 100% because a human body is live and there's different blood systems and other factors, but it's been very accurate, and that's why it's used. It's used in industry to predict how these topicals work. And so what we do at Zion is, as we work with formulations and try to understand, the potential benefits, etc., those front cell experiments are deployed where you can then measure with a certain formulation versus another how much is getting through the skin and how much is staying in the skin over time, because you can take certain cuts over time. You can look at it at 2 hours, 4 hours, 8 hours, 12 hours, 24 hours. So you get essentially what we call a kinetic curve of how that drug is absorbed and distributes and gets taken up as a prediction of how it will work in a human setting. Now, you can do it live also by doing biopsies in people's skin. Now, not great to do biopsies on someone's scalp and leave a hole in their scalp. So let's put it this way, you don't get a ton of people signing up for that study. So it is a lot easier to do it in a lab setting using the France cell system.
That's awesome. That's really cool. I was actually curious about that. And you have the localization and of the medication. You're talking about stopping the DHT at the source of the hair follicle, localizing it in the hair. Kind of how does that work?
Yeah, well, effectively, remember, these medications, they inhibit the 5-alpha reductase enzyme. And actually, for many years, it was thought, in order to benefit hair growth or retention of the hair you have, you got to inhibit 5-alpha reductase in various parts of the body, not just in the hair. And I think with some of our data and others today, I think it's generally now being well accepted that inhibiting 5-alpha reductase in the skin is sufficient, or at least inhibiting it to the largest degree in the skin is sufficient. And essentially what it does is it really is inhibiting that key enzyme that converts testosterone to DHT. And so you have in an individual who's sensitive to DHT, like myself, you now have a lower circulating level of DHT in the target environment, which think about as a toxin. I mean, DHT is important. Testosterone is an important molecule, but in certain individuals, male and some females, that receptor can be very sensitive to DHT and it binds very easily. So the less you have, the less of these receptors get bound. And so the less of that toxic effect of DHT. How that impacts hair miniaturization and ultimately loss or shedding, catagen and exogen phases, etc., is not perfectly understood. But essentially, simply put, DHT is like a toxin that essentially stimulates miniaturization of the hair follicle.
Mhm.
And over time, that hair essentially disappears. And this is one of the very important differentiators of other causes of hair loss, like telogen effluvium, for example, where you can actually see rather normal looking scalp. It just comes out easily. Whereas with androgenic alopecia, you can see these miniaturized hairs. because you get that because of the effect of that androgen receptor and DHT. And so that's how locally finasteride works. Stops all of these DHT molecules easily binding to all of these receptors and causing that toxicity.
It's awesome. I want to pivot to the minoxidil side of things. I know you talk about oral minoxidil, and I think a lot of people are opening up to accepting the low dosages of oral minoxidil. And obviously, we have the topical versions. You also study the heart. And I think the biggest thing with oral minoxidil and topical minoxidil, there's a slight difference there. Could you explain kind of just the difference between oral medication and topical and why I would pick one or the other?
Yeah, it's interesting because, of course, and I'll just remind your audience that it really is only the topical form that has at least got FDA approval for androgenic alopecia, but oral minoxidil is increasingly being used. It was originally, minoxidil was originally developed as an antihypertensive, a drug to treat hypertension, high blood pressure. And of course, individuals taking oral minoxidil for that indication started to develop hair. And of course, it became a huge area of interest. Oral minoxidil has continued to be used for hypertension over the years, although not as a first or second line, usually in people with what we call resistant hypertension, where they're resistant to multiple medicines. So there's much more data with topical minoxidil today and hair loss, because that's the form in which it was originally developed to get approved. And it was thought because, sorry, the sun's shining in my eyes here.
Yeah, you're looking great, man. The sun's
Thank you,
hitting
man.
perfectly.
It's showing off nicely, huh? My dreads. Zeph, and so the topical form was initially developed and what's thought to really be as its mode of action, increasing blood flow by vasodilating or dilating the small capillaries or blood vessels in that hair follicle, and improving essentially nutrient flow and growth factors and all of the good things that are meant to stimulate dermal papillar hair cells to replicate. But, as now has been shown, the oral form is thought to actually have a very significant benefit. And it's really not clear how much of that benefit with oral minoxidil is because of its effect on the scalp versus its effect systemically. And what's really interesting to me is how might that systemic effect actually be improving in a way that you're not going to get the same kind of action with topicals. So we really are waiting for, I would say, long-term, well-controlled studies of oral versus topical minoxidil, which I think would be very cool to see whether there's a difference. Now, of course, one of the things with topical minoxidil, depending on the solution you use, some men can find some of the solutions a bit irritant to the skin. It can dry the skin a bit, and that's why the foam was developed in a way that appears to be better tolerated to the prior solutions. Whereas oral is really not going to have that potential liability, right? I would say with oral minoxidil, however, you're more likely, particularly at higher doses, to have the effects that are more systemic. So hypertrichosis, which is hair growth elsewhere, not just in the head, is something that could be a side effect more prone to with oral minoxidil. Some guys want to grow beards, maybe actually an interesting thing, right?
Not bad for some.
What's that?
Not bad for
Not
some.
bad, not
Maybe
bad for some,
women.
but there are other adverse effects of oral minoxidil not to be taken lightly. Low blood pressure, dizziness, elevation in heart rate, what we call tachycardia. You can get swelling of the legs, what's known as pedal edema, swelling around the eyes. I've got bad bags, but minoxidil can cause what's called periorbital edema. You can get EKG changes with oral minoxidil. So we see this quite commonly in clinical practice, typically when used at high doses. So when I use oral minoxidil for hair loss in patients, I would typically start them on a lower dose, see how they tolerate. And often those lower doses aren't available because the standard doses available are 2.5 and 5. So you can either chop up a 2.5, or there are some companies now that are going to have lower dose minoxidil available, compounded. Start at a lower dose, work your way up as tolerated. But those are the things to think about. Long term with topical, maybe more skin related adverse reactions. Long term with oral, think cardiac, lowering your blood pressure, elevating your heart rate, those kind of things. I think, again, you can get to the right dose. My motto when starting a patient with any treatment is start low and go slow.
Yeah.
Start at a low dose, make sure that that patient tolerates it, go up slowly as they tolerate it over time. There's no absolute rush.
We have 10 minutes left on this recording, so we'll definitely knock out some things. But as a side note, I had this doesn't really have to be for a recording, but I saw some recent studies. I saw two studies that talk about, I forgot the actual medical term for it, but the fluid buildup in the heart on
Yeah.
actual low dose of minoxidil. So there's been two studies recently that shown like a fluid buildup. I think the signs were obviously the face swelling, the legs swelling, but that's always like piqued my curiosity is like, does we don't have to answer this question, but I just thought I'll mention
I
it.
think Zeph, we can see that again in people that are perhaps more susceptible. So that occurring in a guy like you, very unlikely,
Yes, I agree.
extremely. But in
It's
an older
rare.
patient who may have a degree of heart coronary disease, who may have valvular heart disease, who may have propensity to heart failure, for sure, these types of medications can definitely precipitate that kind of side effect. But in a young person with a normal cardiac structure and function, extremely unlikely.
Perfect. I want to get into the dutasteride really fast and just talk about topical dutasteride is relatively pretty new. I want to talk about the absorption of topical dutasteride versus a finasteride absorption with the I forgot what they measure it in, but basically it's slightly over the scalp absorption rate of how to get it into the system. And I kind of want to hear your thoughts on topical dutasteride and how it's able to absorb into the system and
Yeah.
help.
Zeph, topical dutasteride is an interesting option for certain individuals. Of course, it's not FDA approved. It needs to be compounded, but may be suited to certain men and women. Obviously, a big advantage of dutasteride over finasteride, as you probably and many of your audience is aware, is it inhibits or blocks both type 1 and type 2 isoforms of 5-alpha reductase, and it inhibits type 2, which finasteride inhibits about 3 times more potently than finasteride, but inhibits type 1 about 100 times more potently than finasteride. So it's definitely a much more potent medication. It's the reason why when it is used, at least orally, it's used at a lower dose, 0.5 milligrams of dutasteride. Now, you raise an interesting question around the delivery of dutasteride through the skin or topically. Dutasteride is a very lipophilic molecule. It likes fat. It's greasy. It's a large molecule. And the other key difference from finasteride is it's got a very extensive half-life. We think about finasteride half-life in hours, somewhere in the 4 to 6 hours, whereas with dutasteride, like 4 to 6 weeks. So literally that much more extensive to really takes weeks and weeks to wash out. So there are certain elements of dutasteride that make it actually quite well suited to topical delivery. Because it's a lipophilic molecule, it likes fats, likes oils. The skin is actually quite a good depot for that. And so when you deliver a dutasteride, particularly in like a liposomal or a lipid particle, nanoparticle, as a number of as there are a number of those options available, it allows the depoting or the increased residence of dutasteride in the skin, limiting the absorption and with very slow release kinetics.
Mm-hmm.
Now, because it's such a large molecule and it's also highly protein bound, while it likes the skin, you need a lot of it to get through. And so finding the right vehicle that will allow enough dutasteride to get through that stratum corneum, which is the upper layer, the epidermis, into the dermal junction where the hair follicle cells or the papilla are, that formulation needs to be just right. And so it's important to, if one delivers a drug like dutasteride, to understand the kinetics, to understand how these medications work physiologically, to enable us to design a formulation that can allow for the transmission of dutasteride through that upper layer and its residency in that dermal junction longer, with reduction of flux into the rest of the body. It's like a flux system. And you want a drug that essentially can get in and it stays in, but doesn't go down too far. And so there are attributes of dutasteride which are very well suited to the skin, the lipophilicity and the protein binding. The half-life can be taken advantage of. You dose it once a day, and some people, they say, oh, just use it every couple of days. And then, but the large molecular size or molecular weight of the molecule does make it more difficult. So you do need more often to get into the skin. But that is work that has to be done to define what that right dosage is. You can't just come up with a number. And so it's important that as your customers look for options with their doctors, that is a consideration. You don't just put a drug on the skin and just hope for the best. You really want to understand why it's designed and developed in a certain way.
That's Celostic System Gel that you guys formulated is one of the better vehicles. I mean, the best vehicle that I've seen to deliver the drug the way that you would want it to deliver.
Yeah, if doctors want a vehicle that can deliver an active ingredient to the skin in a way that sort of depots and limits the absorption, then, a system like the Celoxa system can be used for sure. It's designed especially for that. And as I said, not all topicals are created equal, and others are just allow for the flux of the drug through the skin into the body. So it really depends on what that customer wants, what their doctor wants, as to what the best system would be to use. But remember, and I always say this, these compounded topical forms are generally reserved for people who, in whom the approved drug doesn't work, they're intolerant of it, they've got side effects, they're really nervous about side effects, and then a compounded form would be the way to go. But that's the sequence we think about in drug prescribing.
Perfect. We got 2 minutes left. I'm going to speed round these for you. We're going to do a mailbag from my followers. This is something off topic here, but we're just going to ask you some questions from my comment section that were most liked. So we got 2 minutes of recording. Let's see how this goes. So quick thoughts on laser light therapy, red light therapy for hair growth.
Yeah, so low-level laser therapy is being commonly used in cases of androgenic alopecia, as well as stress disorders like telogen effluvium. I think I would say worth a try. Definitely not going to replicate the same kind of efficacy as prescription medications will. But as a part of a treatment holistically, with a whole number of factors that we can apply to optimize hair health and scalp health, low-level light probably has a place, but isn't nearly going to be as effective as a prescription medication. So in people who need to really put hair on their head, in and of itself, I don't think it's going to be sufficient.
Perfect. Minoxidil irritates my skin. What are my options to eliminate that dandruff and flakiness buildup from the minoxidil topically?
Yeah, of course, different solutions of minoxidil could be tried. As I said, many of the patients I've seen over years, foam seems to be better tolerated, not all. Of course, oral minoxidil is a very interesting alternative for that individual. And then there are also compounded forms of minoxidil that could be compounded in other gel systems that could be tried, like Celoxa system, for example, or others. We've got various ways of approaching this for people who have side effects with the minoxidil solutions. Minoxidil is an important component of treatment for hair loss for most men. We would advocate for it, but it can cause that dryness. Of course, treating dryness and flakiness with good shampoos, and oils would also be important. And I know